Okay, let's unpack this. Imagine you're standing at the microscope, right? And there's this challenging spindle cell tumor staring back at you.
Hmm.
It's a moment every surgical pathologist faces, often with a mix of excitement and, let's be honest, maybe a little bit of diagnostic trepidation.
Definitely trepidation sometimes. These lesions are just notorious for their incredible mimicry.
Exactly, making them one of the trickiest and maybe highest stakes areas in our entire field.
Indeed. Spindle cell tumors of soft tissue are, well, they're a persistent source of diagnostic problems. You're not just trying to distinguish benign from malignant,
Right.
or even a true sarcoma from its many non-mesenchymal mimics.
Yep.
You're also trying to accurately classify them, grade them,
Uh-huh.
and often with features that overlap, which complicates the picture significantly. It's a true test of your diagnostic skills.
That's why our deep dive today is really tailor-made for you. Listening out there, maybe a surgical pathologist, fresh out of fellowship, looking to really sharpen those independent practice skills.
Yeah, getting ready for those board-style challenges, too.
Exactly. So we're taking a deep, detailed look at adult spindle cell tumors, trying to extract the most important nuggets of knowledge to get you truly ready for anything that comes across your scope.
Our mission is precisely that. We want to arm you with a structured, kind of in-depth approach. We'll cover the key clinical contexts, the critical morphologic parameters,
Mm-hmm.
the invaluable role of ancillary techniques like IHC and molecular genetics, and crucially, how to confidently navigate those complex differential diagnoses that really define this area.
So the idea is a robust framework.
Exactly. Based on extensive source material, allowing you to approach these cases with significantly greater confidence.
Ready to dive deep into the fascinating and, okay, sometimes frustrating world of adult spindle cell tumors.
Let's do it.
Let's get started. So to kick us off, what makes these spindle cell tumors such a diagnostic tightrope walk for us? What are the core challenges we're always up against when one lands on our bench?
That's a great way to put it, a tightrope walk.
Yeah.
There are really three primary issues, I think, that constantly vex surgical pathologists and make these cases so difficult.
Okay.
First, and arguably the most crucial for patient management, is differentiating those non-mesenchymal malignant spindle cell neoplasms. Think things like sarcomatoid carcinomas or melanomas from true sarcomas.
Right. The imposters.
Exactly. You absolutely do not want to misdiagnose a metastatic carcinoma as a primary soft tissue sarcoma or vice versa. The treatment implications are just vastly different.
Huge difference.
Incredibly high stakes there. Second, you're constantly engaged in that fundamental task of distinguishing a truly benign spindle cell lesion from a malignant one.
Benign versus malignant.
This is
Yeah.
all about prognosticating correctly for the patient, right?
Okay.
Preventing unnecessary aggressive treatment for something benign, or ensuring timely life-saving intervention for a malignancy. And third, once you've established it as a sarcoma, you're tasked with accurately classifying and grading it. That directly guides the specific treatment protocols, everything from surgical margins to adjuvant therapies.
And it's not always straightforward.
Oh, not at all. To complicate matters further, features like, say, prominent myxoid stroma, or a dense inflammatory infiltrate, or even just degenerative changes can really obscure the true nature of a lesion. It makes a clear-cut diagnosis quite elusive, even for experienced eyes sometimes.
So it's clearly not just about what we see down the scope on an H&E, is it? You
Mhm.
really can't just rely on morphology alone for these tricky cases, no matter how good your eye is.
Absolutely not. I mean, morphology is foundational, obviously, but the diagnostic approach must primarily be based on a solid understanding of the relative frequencies of different tumor types.
Knowing the odds, basically.
Exactly. Knowing what's common in a particular site or age group can be your first, most powerful filter. Then, appropriate consideration of the clinical context is paramount. It offers invaluable clues before you even touch a slide. And, of course, a correct interpretation of the morphologic features on the H&E stain remains the bedrock.
But often that's not enough.
Often it's not, especially with spindle cell tumors.
Wow.
So when those initial assessments aren't definitive, and they often aren't, ancillary techniques, particularly immunohistochemistry, IHC, and molecular genetics, are invaluable tools.
Right.
They've effectively replaced older methods like ultrastructural studies. They're just more widely available, easier to apply, faster turnaround, more cost-effective.
Makes sense.
So the practice points for you as you step into independent practice are clear. Always, always exclude non-mesenchymal mimics first. That's job one.
Okay.
Then, if possible, classify the tumor specifically. Determine if the tumor is benign or malignant. If it's a sarcoma, provide the histologic grade if that's appropriate for that tumor type.
And if you can't classify it,
Even when a definitive classification isn't possible, you must provide clinically relevant information. Things like the status of excision margins, the probable line of differentiation, the presence of aggressive features, and your most likely differential diagnosis.
given something to work with.
Exactly. This comprehensive, systematic approach is what builds diagnostic confidence and ensures the best patient care.
You mentioned clinical context as a critical filter, and it sounds like it can really save you some headaches.
Yeah.
How do those simple parameters like age, gender, and anatomic location become such powerful diagnostic aids in these complex spindle cell cases? They seem so basic, but crucial, right?
Oh, they are absolutely crucial. They are often the first major clue in narrowing a wide differential, sometimes before you even look at a slide.
Really?
Yeah, think of it this way. A patient walks in with a mass. Before you even get a biopsy, you have these pieces of information. For instance, nodular fasciitis, fibromatosis, and synovial sarcoma. They most often arise in young adults.
Okay, young adults for those.
Right, that's a crucial distinction. It can immediately shift your mental differential. In contrast, solitary fibrous tumor, or SFT, leiomyosarcoma, spindle cell carcinoma, spindle cell melanoma, they usually affect patients 40 years or older.
Got it. Age is a big divider.
Huge. Patient gender also offers vital hints. Myoparasitoma, for example, shows a clear male predominance.
Okay.
While elastofibroma is much more common in elderly women, just knowing these simple demographics can quickly narrow down your possibilities from dozens to maybe a handful.
And location.
Location is key, too. If you look at Table 3.2 in our source material, it highlights this. A pseudosarcomatous myofibroblastic proliferation, or PMP, has a strong predilection for the urinary tract.
Very specific.
Very specific. Intranodal palisaded myofibroblastoma occurs specifically in inguinal lymph nodes. Then there's the patient's history, like in box 3.1. Trauma is commonly associated with nodular fasciitis.
Wait.
A history of neurofibromatosis type 1, NF1, immediately raises concerns for neurofibromas, GIST, or malignant peripheral nerve sheath tumors, MPNST.
Okay, NF1 is a big red flag.
Absolutely. Pregnancy can be linked to abdominal fibromatosis, diabetes with palmar or neutral-type fibromas. These associations are critical for you. Don't overlook them. They provide invaluable context that can point you toward or away from certain diagnoses, saving you a lot of time and potential missteps. Sometimes they even lead you straight to the right answer.
Okay, so once we have that clinical picture, that crucial context, what are the most critical morphologic features on an H&E stain that truly guide our eye? What are we really looking for under the scope that differentiates these myriad entities, especially when they all kind of look like spindles at first glance?
Yeah, that's the million-dollar question for every pathologist, isn't it? How do you tell these spindles apart? Well, it's similar to other mesenchymal neoplasms, but the interpretation is highly nuanced for spindle cells.
Okay.
First, you evaluate the architectural arrangement. Are the cells in long fascicles, short fascicles? Do they form whorls, sheets, or do they just look haphazard? This gives you a sense of the tumor's fundamental growth pattern.
Like its basic structure.
Exactly. Second, the interface between the tumor and adjacent tissues is key. Note if the borders are pushing or expansile, that might suggest benignity or low grade. Or are they diffusely infiltrative? That often suggests malignancy, but importantly, not always.
Okay, borders are critical.
Critical. Third, assess the amount and type of extracellular matrix. Is there a lot of it? Or is it scant? Is it densely collagenous, hyalinized, maybe myosoid? This provides a crucial textural element to the diagnosis.
Right, the background stuff.
The background stuff, yeah. Fourth, intratumoral vascularity is vital. Are the vessels well developed or are they inconspicuous? Are they thick-walled, hyalinized, or are they forming those classic branching hemangiopericytoma-like vessels, the HPC-like pattern? Fifth, the presence or absence of tumor necrosis. That's a major red flag, often indicating malignancy. You really have to hunt for it.
Necrosis bad, generally.
Generally, yes. Finally, and perhaps most importantly, meticulously analyze the precise cytomorphology. Observe the spindle cell length. Are they long and thin, short and plump? Are they uniform, or is there significant pleomorphism? Look at the quality and amount of cytoplasm. Is it eosinophilic, pale, clear?
The details of the cells themselves.
Exactly. And the nuclear features, vesicular chromatin, prominent nucleoli, nuclear grooves, tapering ends or blunt ends. And of course, you must meticulously evaluate mitotic activity. Look for both typical mitosis and especially any atypical mitotic figures. Count them carefully.
That's a really comprehensive breakdown. And it brings me to something I've always found challenging. How do you interpret things like mitotic activity? Because, like you said, in some spindle cell lesions, Britt's mitosis are perfectly fine, almost expected. But in others, even one mitosis can scream malignancy. What's the nuance there?
That's an excellent point, and it's where experience really comes into play and knowing the specific entity you're potentially dealing with. A critical point to remember and maybe burn into your brain is that infiltrative borders, necrosis, atypical nuclei, and mitotic activity may or may not indicate malignancy. It depends entirely on the specific line of differentiation and the tumor type.
Context again.
Context. It's a common pitfall. For instance, any mitotic activity in a deep, smooth muscle tumor or a neurofibroma usually indicates malignancy. The threshold for concern is incredibly low there.
Okay, very low threshold for those.
Right. However, in myofibroblastic or fibrohistiocytic lesions like nodular fasciitis, brisk mitotic activity is perfectly compatible with a benign diagnosis. That cell line just naturally has a high turnover.
But depends. Always it depends.
Exactly. Always remember that it depends when looking at those features in isolation. You have to integrate everything.
Okay, so before we even think mesenchymal, you mentioned this crucial first step of excluding non-mesenchymal mimics. Why is this so paramount? Why is it the absolute first thing we, as pathologists, should consider when faced with a spindle cell lesion?
Because they can be perfect imposters. Morphologically, they can look identical to true sarcomas. And misdiagnosis carries really significant clinical consequences for the patient.
Right. Different treatments entirely.
Completely different treatments. Misdiagnosing a carcinoma as a sarcoma, or vice versa, can lead to completely inappropriate therapy. You might delay life-saving treatments or subject a patient to unnecessary surgeries. Spindle cell carcinoma and spindle cell melanoma are the most common and, frankly, the most dangerous of these mimics. You need a high degree of suspicion to avoid these diagnostic pitfalls.
So your first job is rule out the imposters.
Always. Job number one.
Okay, let's break them down. Spindle cell carcinoma.
Right. Spindle cell carcinoma, sometimes called sarcomatoid carcinoma. This entity is a true chameleon. It can arise virtually anywhere in the body, usually affecting middle-aged to elderly adults. Common sites: sun-exposed skin, respiratory tract, digestive tract, thyroid, urinary system, genital system, basically anywhere.
Pretty widespread.
And a crucial piece of clinical history to get. Sarcomatoid carcinoma can also be a metastatic deposit, especially from kidney or lung primaries. So knowing if the patient has a prior history of malignancy is incredibly relevant.
Good point. Ask for the history.
Definitely. Histologically, it often beautifully mimics undifferentiated spindle cell sarcomas. It can have store-form patterns, fibrosarcoma-like patterns, even those HPC-like vascular patterns.
So how do you tell?
The diagnostic key, when you can find it, is detecting better differentiated epithelial areas or maybe an in situ component nearby.
Finding the carcinoma part.
Exactly. Even small foci are your strongest clues. For immunohistochemistry, even focal expression of keratins or P63 or epithelial membrane antigen EA is supportive. You might need to use multiple broad-spectrum keratin antibodies to unmask that epithelial differentiation.
Okay, use a panel.
Use a panel. And critically, remember, Vimentin is not helpful here.
Why not?
Because it's not specific for mesenchymal tumors. It's often co-expressed in sarcomatoid carcinomas. So don't let a Vimentin-positive result lead you astray from carcinoma.
Got it. Vimentin doesn't rule out carcinoma.
Yeah, not at all. The key nugget here: always hunt for that subtle epithelial component, either morphologically or by IHC.
Okay, good takeaway. What about spindle cell melanoma?
Next up, spindle cell melanoma and its variants, particularly desmoplastic melanoma. First off, metastatic melanoma, especially to soft tissue or lymph nodes in places like the axilla and groin, should always be on your differential. Sometimes that's the initial presentation of the disease.
So melanoma can present in soft tissue first.
Absolutely. Spindle cell melanoma itself shows, well, typical spindle cell morphology, often vesicular chromatin, maybe a high mitotic rate, easily mistaken for a high-grade sarcoma.
Okay.
Desmoplastic melanoma, however, this one can be deceptively bland, really bland.
Yeah, so
It's often paucicellular, meaning not many cells, and very scar-like. Just vague fascicles of spindle cells and an abundant collagenous stroma. Frequently, there's a peripheral lymphoid infiltrate. The scar-like appearance is a huge pitfall. It often leads to underdiagnosis if you're not thinking about it.
Looks like scar tissue, but it's melanoma.
Exactly. Immunostains are vital here. Strong and diffuse expression of S100 protein and SOX10 is characteristic of melanoma. That strongly argues against something like an MPNST.
S100 and SOX10 are key.
Key markers. However, a crucial practice point. Be aware that the second-line melanoma markers like HMB45 and melan A are usually negative in spindle cell melanoma.
Oh, that's important.
Very important. So relying solely on HMB45 or melan A can lead you to miss the diagnosis. Stick with S100 and SOX10 primarily.
Okay, so the nugget for melanoma. Desmoplastic type can look incredibly bland, almost scar-like. S100 and SOX10 are your best friends here. Don't rely on HMB45 melan A.
Precisely. And finally, in the mimic category, we have malignant mesothelioma, particularly the sarcomatoid type.
Okay, mesothelioma.
This can be a tough one because localized sarcomatoid mesothelioma can easily be confused with various spindle cell mesenchymal neoplasms, MPNST, synovial sarcoma, SFT, undifferentiated sarcomas, you name it.
Another good mimic.
A very good mimic.
Yeah.
And the hypocellular desmoplastic mesothelioma variant can even resemble benign fibrosing processes or even a desmoid tumor.
Wow. Okay, clinical clues.
Clinical clues are vital. A history of asbestos exposure, obviously, or prior radiation therapy. Recurrent serosal effusions are a big one. And finding a mass based on a serosal surface like the pleura or peritoneum, these details are extremely important and should prompt a specific workup.
Right. The location and history points you there.
Exactly. Immunoreactivity for keratins, EMA, calretinin, WT1, specifically nuclear pattern, and protoplanin, D240, are helpful. But here's the catch. Many sarcomatoid mesotheliomas, maybe up to 60%, can be negative for mesothelial markers, including calretinin.
So the markers can fail you.
They can. In those challenging cases, WT1 is typically the most sensitive mesothelial marker to rely on.
Okay, WT1 is the go-to if others are negative.
Often, yes. So, in summary, always start your diagnostic journey by thoroughly ruling out these non-mesenchymal imposters, carcinoma, melanoma, mesothelioma. Your patients depend on it. The key takeaway for sarcomatoid mesothelioma: think history of asbestos, think serosal location, and remember, WT1 is often your most reliable IHC marker when others fail.
All right. Now that we've set the stage and talked about those critical non-mesenchymal imposters, let's pivot to the truly mesenchymal lesions, starting with the benign ones. I want to begin with a classic mimic, or nodular fasciitis. This one always seems to trip people up because of its rapid growth, making you think it's something far more sinister, right? How do we spot it and differentiate it confidently?
Yeah, nodular fasciitis is a perfect example of why clinicopathologic correlation is so critical. It usually shows up in young to middle-aged adults, typically between 20 and 40. No real gender preference.
Okay, young adults.
And it often presents as a solitary small lesion, usually less than 2 or 3 centimeters. Crucially, it develops rapidly. We're talking maybe 4 to 8 weeks from nothing to a noticeable lump. Patients might even say it's painful.
Rapid growth is key. Where does it usually pop up?
Common sites are the upper extremities, especially the forearm or the head and neck. Grossly, it's usually well circumscribed. It looks kind of myxoid when it's young and firmer, more fibrous as it matures.
Okay, and under the scope.
Histologically, early lesions show these plump fibroblasts and myofibroblasts. They're arranged in short, irregular fascicles, sometimes with a vague storiform pattern. They sit in a loose myxoid matrix, almost looks feathery, or maybe a more collagenous stroma.
Plump cells, feathery background.
Exactly. The cells themselves are plump, lots of eosinophilic cytoplasm, truly resembling cells you'd see in tissue culture. They have vesicular nuclei with prominent nucleoli.
Okay, sounds active. What about mitosis? That's the scary part.
Right, and what's crucial here, and often a cause for concern, is that mitoses can be numerous, sometimes very brisk, but they are always typical, normal-looking mitoses.
Always typical. That's the key differentiator.
Absolutely key. You'll often see an inflammatory infiltrate too, maybe some extravasated red blood cells and capillaries kind of radiating inwards. Long-standing lesions become less cellular and more fibrotic, scar-like.
And molecular, you mentioned something there.
Yeah, what's fascinating is that despite the clinical features suggesting it's just reactive, it's actually a clonal proliferation. It's driven by USP6 rearrangements, commonly the MYH9 USP6 gene fusion. Finding that fusion basically confirms its benign nature.
So molecular can nail the diagnosis if morphology is tricky.
It really can. Now, differential diagnosis. Nodular fasciitis is frequently mistaken for sarcoma.
Yeah.
Maybe 20% to 30% of cases get overcalled initially.
Why?
because of the cellularity, the rapid growth, and that brisk mitotic activity. But unlike most sarcomas, it consistently lacks enlarged or really hyperchromatic nuclei. It doesn't have tumor necrosis, and importantly, no atypical mitotic figures.
Okay, what else does it mimic?
Well, myxoid examples can be confused with myxofibrosarcoma, but myxofibrosarcoma usually happens in the elderly and has truly hyperchromatic nuclei.
Different age group, different nuclei.
Right, or it could mimic low-grade fibromyxoid sarcoma, LGFMS, but LGFMS is MUC4 positive, which nodular fasciitis isn't. Hypercellular forms might make you think of leiomyosarcoma or even spindle cell carcinoma, so you'd need specific IHC panels to sort that out. And the rare ossifying forms need careful distinction from extraskeletal osteosarcoma, which generally has more atypia, necrosis, and less organized bone formation.
Lots of mimics.
Lots of mimics, but manageable. So the key takeaway for nodular fasciitis: a rapidly growing, small, often superficial lesion in a young adult with brisk but always typical mitosis, and if you can get it, the USP6 fusion confirms it's benign.
Okay, so if you see that rapid growth, don't panic. Look for those typical mitoses and maybe consider the USP6 fusion. Great example of molecular sealing the deal. Building on that, what about pseudosarcomatous myofibroblastic proliferation, PMP? How does that differ from nodular fasciitis, and what are its key features?
Good transition. PMP is similar to nodular fasciitis in its myofibroblastic nature, but it often presents in mucosal sites and sometimes appears postoperatively, like after surgery.
Mucosal sites like where?
PMP predominantly affects adults and is most common in the genitourinary tract, bladder, prostate, that area. It often presents as exophytic or polypoid masses.
Okay. Histology.
Histologically, it's a spindle cell proliferation in loose fascicles. The cells are plump, sometimes even mimicking rhabdomyoblasts. They have vesicular nuclei and prominent nucleoli, similar to nodular fasciitis. But crucially, nuclear pleomorphism, atypical mitosis, and necrosis are typically absent.
Absence of atypia is key.
Absolutely key. It often expresses muscle-specific actin and smooth muscle actin, maybe focal desmin and keratin positivity sometimes. But it's consistently negative for S100 and CD34. Now, here's an interesting overlap. About 50% express ALK by IHC.
ALK, like an IMT.
Exactly, which creates a significant overlap with inflammatory myofibroblastic tumors, or IMTs. So the pragmatic approach many take is to classify ALK-rearranged lesions as IMTs and the ALK wild-type ones as PMPs.
Okay, that makes sense. ALK status helps classify.
It does. The key distinguishing feature from more aggressive things like leiomyosarcoma or sarcomatoid carcinoma is that consistent lack of significant atypia in PMP. It typically doesn't recur after complete excision, even though it can look a bit worrying sometimes.
So the key nugget: PMP is a reactive-looking lesion, often in mucosal sites, especially GU tract, and the absence of true atypia is your main differentiating factor from sarcomas.
You got it.
Okay, that clarifies PMP nicely. Let's shift gears to tumors with perovascular myeloid differentiation. What are the essential points for myofibroma and myopericytoma?
Right, so myofibroma and myopericytoma are grouped together. Both are benign tumors showing perivascular myoid differentiation. Adult myofibroma is usually a solitary, painless nodule. Common spots are head, neck, or lower extremity. It's characterized by this biphasic appearance, highly cellular areas with prominent thin-walled vessels surrounded by nodular, fascicular myoid areas.
Biphasic pattern and myopericytoma.
Myopericytoma is closely related, but it specifically shows spindle cells concentrically arranged around blood vessels, like little onions.
Concentric growth. Molecular.
Molecularly, myofibromas are characterized by activating PDGFRB mutations. Both are benign and rarely recur after simple excision, so surgical removal is usually curative.
Pretty straightforward benign lesions then?
Generally, yes. The takeaway here: look for that characteristic perivascular growth pattern biphasic in myofibroma, concentric in myopericytoma, and remember they are typically benign with PDGFRB mutations, often in myofibroma.
Now, for an entity that's rare, but when you see it, the clinical picture often gives it away immediately. Phosphaturic mesenchymal tumor, PMT. What makes this one so distinctive?
PMT. Yes, this is a fascinating one. It's a rare, distinctive mesenchymal neoplasm. Can arise in soft tissue or bone, and it's often associated with a striking clinical paraneoplastic syndrome. Hypophosphatemic osteomalacia.
Right, the phosphate wasting syndrome.
Exactly. Patients are typically middle-aged. They present with things like stress fractures, bone pain, and the lab findings are characteristic. Low serum phosphate, high urine phosphate.
The labs are a huge clue.
Huge clue.
Ah,
Histologically, PMT has varied appearances, but it's consistently low cellularity, bland cytology. It has prominent vasculature, often with those branching HPC-like vessels we talked about. Flocculent calcification, sort of fluffy calcifications, are typical.
okay, bland cells, vessels, flucky calcifications, molecular markers.
Key molecular features include recurrent gene fusions like FN1, FGFR1, and FN1, FGF1. And the crucial insight here is that FGF23 secretion by the tumor cells is actually what causes the osteomalacia.
Wow, the tumor makes the hormone.
Precisely. The differential diagnosis includes SFT, but SFT lacks that calcified chondromyxoid matrix typical of PMT. Myofibroma could also be considered. But the really rewarding part, complete resection of the PMT typically resolves the osteomalacia completely.
A cure by excision.
Exactly. A truly rewarding diagnostic therapeutic correlation. So the key nugget. If your patient has unexplained hypophosphatemia and bone pain, even a bland spindle cell lesion needs to be considered PMT until proven otherwise. Look for those FN1 fusions and FGF23.
That's a great example of integrating clinical data with morphology and molecular findings. What about myofibroblastoma and its variants? We see these in specific sites, right?
Absolutely. Moving on to myofibroblastoma and its variants. First, there's mammary-type myofibroblastoma, often seen in older males, actually, despite the name.
Older males, okay.
It's closely related to spindle cell lipoma. Histologically, it's characterized by fascicles of spindle cells in a collagenous stroma, often with an adipocytic component mixed in.
Like spindle cell lipoma.
Very much so. It's positive for Desmin and CD34, and frequently shows RB1 loss by IHC. Molecularly, it's identical to spindle cell lipoma with 13q deletions.
So basically a variant of spindle cell lipoma.
Essentially, yes, just often lacking significant fat. Then there's intranodal palisaded myofibroblastoma. This is a benign intranodal proliferation, primarily found in inguinal lymph nodes.
Inguinal nodes specifically.
It's distinguished by striking nuclear palisading nuclei lining up and abundant eosinophilic fibrillary material known as amianthoid fibers. Looks almost like asbestos fibers, but it's collagen.
Amianthoid fibers, okay. Molecular.
This tumor harbors CTNNB1 hotspot mutations. That leads to nuclear beta-catenin expression by IHC.
Like desmoids.
Similar pathway activation, yes, but a very different entity clinically and morphologically. These specific features, location, palisading, amianthoid fibers, CTNB1 mutation, are key to its identification.
Got it. So the takeaway. Mammary type is linked to spindle cell lipoma and RB1 loss. Intranodal palisaded myofibroblastoma is in inguinal lymph nodes with palisading amianthoid fibers and CTNNB1 mutations.
Perfect.
Now, a big family of lesions that can often look deceptively similar, the fibroma family. Can you give us the quick hit differentiating points for the various fibroblastic lesions we encounter? Seems like there are quite a few.
There are quite a few, but each has specific characteristics you need to know. Let's run through them. First, fibroma of tendon sheath. Rare, small, firm nodule, usually hands, feet of adults, attached to tendons. Hypocellular, collagenous, thin-walled, curvilinear vessels, often expressed as SMA. Can have a translocation T211, Q31, Q12, involving MYH9 USP6, interestingly, like nodular fasciitis, but looks very different.
Okay, tendon sheath, hands, feet. Next.
Second, desmoplastic fibroblastoma, also called collagenous fibroma, uncommon deep-seated paucicellular tumor, widely spaced stellate fibroblasts in an edematous to fibromyxoid stroma, also linked to 11q12 alterations involving FOSL1.
Deep paucicellular stellate cells. Got it.
Third, Nutschall-type fibroma, collagenous lesion in the posterior neck, usually of middle-aged men, often associated with diabetes mellitus. Characterized by thick hyalinized collagen bundles, entraps small nerves and fat. Morphologically, it's nearly indistinguishable from Gardner fibroma.
But the context is different.
Exactly. Gardner fibroma occurs in children and is linked to FAP and APC mutations. Neutral-type fibroma is sporadic in adults, often with diabetes.
Okay, posterior neck, thick collagen, association with diabetes.
Fourth, elastofibroma. Uncommon lesion, typically in the scapular area, subscapular, in elderly women, defined by its hallmark, numerous, large, fragmented elastic fibers. You need an elastic stain like for Hoof van Giesen to really see them well.
Elastofibroma, elastic fiber, scapula, elderly woman.
You got it. And finally, calcifying fibrous tumor. Typically in children and young adults, it's a hypocellular lesion, dense stromal collagen with semimatous and dystrophic calcifications scattered throughout. Often CD34 positive.
Calcifications are the key there.
Yes. So the core nugget for the fibroma family. They are generally benign, but each has a specific clinical context, location, age association, or a unique histological element. Curvilinear vessels, stellate cells, thick collagen, elastic fibers, calcifications that helps in diagnosis.
Okay, that helps break them down. What about angiofibroma of soft tissue?
Right, angiofibroma of soft tissue. This is a benign soft tissue tumor characterized by uniform, bland spindle cells. They sit in a variably myxoid to collagenous stroma. The key feature is a prominent, complex vascular pattern, lots of thin-walled branching vessels and larger HPC-like vessels.
Land cells, prominent vessels, cytology.
Cytology is really non-distinctive. No atypia, no mitosis. IHC is not highly diagnostic either, but it harbors a characteristic AHRR-NCO8 fusion gene from a T58 translocation.
A specific fusion.
Yes, that fusion is pretty specific. It needs to be differentiated from SFT, which is SET6 positive, or LGFMS, which is MUC4 positive, or myxoid liposarcoma, which has lipoblasts and delicate capillaries. Angiofibroma is generally benign, with rare recurrences.
So the key here is bland cytology plus HPC-like vessels, and if you can get it, that specific AHRR-NCOA2 fusion.
Exactly. Next, deep fibrous histiocytoma, often considered SFT's tricky cousin.
Why tricky?
It's an uncommon variant of fibrous histiocytoma that arises in subcutaneous and deep soft tissue. It's well circumscribed, usually. Has a monomorphous cellular appearance and a prominent HPC-like vascular network, often strongly positive for CD34. It tends to have a more prominent store-form architecture than SFT does.
Okay, looks like SFT CD34 positive.
Right. And while it's often benign, it does have occasional metastatic potential, maybe 1% to 2%, so it's not entirely without risk. The main differential is cellular SFT.
So how do you tell them apart?
The key to distinction is STAT6 expression by IHC. STAT6 is specific for SFT and typically negative in deep fibrous histiocytoma.
STAT6 is the decider.
It's usually the critical differentiator, so the nugget. It's a deep CD34 positive lesion that looks like SFT but lacks STAT6 expression.
That's a great segue to solitary fibrous tumor, SFT itself. The term HPC used to be everywhere for these, but now it's largely discouraged and often referred to as SFT. Can you explain this crucial shift in the evolution in our understanding of these tumors and why they're so important in practice?
Indeed, the term hemangioparasitoma, or HPC, is largely discouraged today. You really should avoid using it in your practice reports.
Why the change?
Because HPC described a vascular pattern, those branching, thick-walled vessels, which, while prominent in SFT, is actually seen in many unrelated tumors. Using the term HPC led to a lot of diagnostic confusion over the years. SFT is now the preferred and more accurate term, representing a distinct biological entity.
Okay, so SFT is the correct term. Where do they usually occur?
It most often arises in the pleura, that's the classic location. But importantly, SFT can be found virtually anywhere in the body, head, neck, abdomen, soft tissues, you name it. So you need to keep it in mind for diagnosis even in unusual sites.
And who gets them?
It commonly affects middle-aged adults. Often presents as a slow-growing mass, sometimes reaching very large sizes before detection.
Okay. Histology. What defines SFT?
Histologically, SFT exhibits a truly patternless architecture. That's a key concept. It lacks a defined structure like clear fascicles or whorls. It has variable cellularity, sometimes very cellular, sometimes less so. Prominent stromal collagen is typical. And those classic ectatic, branching, thick-walled vessels that were once termed HPC-like?
The patternless pattern with HPC vessels.
Exactly. Mitosis are usually sparse and necrosis is rare, but if present, these features can indicate malignancy. The most reliable criterion for malignancy is generally considered a mitotic rate of 0.4 mitosis per 10 high-power fields.
4 mitosis per 10 HPF is the cutoff.
That's the generally accepted threshold for malignancy, yes. Importantly, SFT can also undergo dedifferentiation. It can transform into a high-grade anaplastic component, which looks much uglier and is associated with aggressive behavior. You have to recognize that if it's present.
Okay, dedifferentiation is a risk. What about IHC?
For IHC, STAT6 is the most useful diagnostic marker. It shows strong and diffuse nuclear expression in over 95% of cases. It's really the defining marker now. CD34 is also commonly positive, but less specific than STAT6.
STAT6 is the go-to. Molecular.
The diagnosis has been greatly simplified by the discovery of the recurrent MB2 STAT6 gene fusion. This results from a paracentric inversion on chromosome 12, which leads to that STAT6 nuclear upregulation seen on IHC.
So the molecular explains the IHC.
Precisely. Different fusion variants actually correlate with specific histomorphology and even clinical behavior. Some variants are associated with a more aggressive course, particularly when they occur in extrathoracic locations or in younger patients.
Interesting. Can molecular predict malignancy?
Not perfectly. There's no single molecular marker for malignancy yet. But things like increased copy number changes, TP53 mutations, and TERT promoter mutations are associated with more aggressive cases.
Okay, so morphology still matters for predicting behavior.
It does, but despite all these advances, the relationship between morphology, molecular findings, and clinical outcome can be notoriously inconsistent in SFT.
Meaning?
Meaning, long-term follow-up is mandatory for all patients with SFT, even the ones that look totally bland. No SFT can be definitively considered benign because late recurrences and metastases can occur years, even decades later. This is a critical practice point for you to relay to clinicians.
Wow, okay, so never call an SFT completely benign. Variants.
Yes, we also recognize variants. Giant cell-rich SFT, which used to be called giant cell angiofibroma, contains numerous stromal giant cells lining pseudovascular spaces. Fat-forming SFT, previously lipomatous HPC, includes mature adipocytes mixed in, and meningeal SFTs, which were previously called meningeal HPC, are now recognized as cellular forms of SFT. They tend to be more aggressive, partly due to frequent incomplete excision in the meninges.
Got it. Differential diagnosis must be broad.
Incredibly broad. It includes everything from deep fibrous histiocytoma, where STAT6 is critical for distinction, to various liposarcoma subtypes, synovial sarcomas, MPNST, you name it. The key is integrating all the data: clinical, morphologic, IHC, and molecular.
In treatment.
Complete surgical excision with clear margins is the goal. Adjuvant radiotherapy might be used for larger or malignant cases.
So the key takeaway for SFT, STAT6 positivity and the EBI2 STAT6 fusion are definitive. But remember, long-term follow-up is essential for all SFTs, as even bland ones can recur or metastasize years later.
You absolutely nailed it. That's the most important message for SFT.
That's a huge point about long-term follow-up, emphasizing that even benign-looking SFTs can surprise you. Let's move to fibromatosis, a group where local behavior can be very aggressive, but they don't metastasize. What are the key types we see in adults, and how do we distinguish them from potential sarcomas that do metastasize?
You're right. Fibromatoses are infiltrative locally, sometimes very aggressively so, but they are non-metastasizing. That's a crucial distinction from true sarcomas. We primarily divide them into superficial and deep forms.
Okay, superficial first.
Superficial fibromatoses include things like palmar fibromatosis, better known as Dupuytren disease, and plantar fibromatosis, or Lederhosen disease. They're benign, but notorious for occurring after excision.
Dupuytren's in the hand, Lederhosen in the foot.
Exactly. Palmar fibromatosis typically affects middle-aged to elderly men, causing those subcutaneous nodules and contractures in the palm. Plantar fibromatosis is more common in young adults and can be quite hypercellular sometimes, occasionally getting mistaken for sarcoma due to its cellularity.
What do they look like histologically?
They show a monotonous proliferation of bland fibroblasts with variable amounts of collagen. They often infiltrate the underlying aponeurosis. They're typically positive for SMA, smooth muscle actin, often show aberrant nuclear beta-catenin expression by IHC, but here's a key point. They lack APC or CTNNB1 mutations.
No mutations, unlike deep fibromatosis.
Correct. That distinguishes them genetically from deep fibromatosis. They do, however, show various chromosomal abnormalities like trisomies 7, 8, and 14.
Okay, now, deep fibromatosis, the desmoids.
Right. The more clinically significant entity is deep fibromatosis, often just called desmoid fibromatosis or desmoid tumor. This is a genuinely infiltrative myofibroblastic neoplasm. It has significant local recurrence potential, but again, importantly, no metastatic potential.
Where do desmoids typically arise?
They can arise in several locations. The abdominal wall, often in young women after pregnancy. Extra-abdominal sites like the limb girdles, chest wall, or intra-abdominal locations, mesentery, pelvis, retroperitoneum. Intra-abdominal ones can get very large and cause compression symptoms.
And histology.
Histologically, desmoid fibromatosis consists of long, sweeping fascicles of bland-looking spindle cells. They have prominent collagenous stroma and often contain medium-sized, thick-walled blood vessels.
Sounds bland but infiltrative. What's the molecular driver?
The defining feature is the dysregulation of the WANT signaling pathway. This leads to aberrant nuclear and cytoplasmic beta-catenin expression by IHC in about 80% of cases. You can see that strong nuclear blush.
Beta-catenin is key. What causes that?
It's caused by activating mutations in the CTNNB1 gene in most sporadic cases. Or, in patients with familial adenomatous polyposis, or FAP, specifically Gardner syndrome, it's due to germline inactivating mutations in the APC gene.
So genetics differ between sporadic and FAP-associated cases.
Yes, but both lead to WNT pathway activation and nuclear beta-catenin. Now, treatment is evolving. While surgical excision with clear margins was the traditional goal, studies show inconsistent relationships between margin status and recurrence.
Meaning surgery might not always prevent recurrence.
Exactly, which has led to a reevaluation. Sometimes less radical surgery combined with systemic therapies like antiestrogens or tyrosine kinase inhibitors, such as imatinib, is used as an evolving management strategy for these often challenging recurring lesions.
Interesting. So the key nugget for fibromatosis: they infiltrate relentlessly, but do not metastasize. Beta-catenin nuclear expression by IHC is your best diagnostic friend for desmoids, driven by CTNNB1 or APC mutations.
Perfectly summarized.
Okay, let's touch on spindle cell lipoma. It's a lipoma, but you said it could be mostly spindle cells, right?
Huh.
Making it a mimic.
Yes, exactly. While often discussed elsewhere due to its adipocytic component, spindle cell lipoma is important here because it can be predominantly spindle cell, sometimes with very little fat, making it a significant mimicker of other spindle cell tumors.
Okay. What are its features?
Grossly, it's usually well circumscribed, often in the posterior neck or upper back of older men. Histologically, it shows uniform spindle cells arranged in short bundles. There are characteristic thick, ropey collagen bundles mixed in, and often numerous interstitial mast cells.
Ropey collagen and mast cells.
Yeah.
Key features.
Very key features. The adipocytic component can be minimal or even absent. Some tumors have prominent myxoid stroma, which further complicates the diagnosis. They are strongly and diffusely positive for CD34. And crucially, they show loss of RB1 expression by IHC.
RB1 loss.
Yes, reflecting underlying chromosomal abnormalities involving chromosome 13q and also 16q. It's often confused with schwannoma, paraneurioma, or even low-grade MPNST. But its specific features, the ropey collagen, the CD34 positivity, and especially that RB1 loss, usually help distinguish it.
Key takeaway: ropey collagen, CD34 positivity, and RB1 loss in a subcutaneous spindle cell lesion, especially in an older male's neck back, strongly points to spindle cell lipoma.
You got it.
Okay, let's talk about the nerve sheath tumors. Schwannoma and its variants are common benign entities, but their variants can be quite diverse and sometimes concerning morphologically, right? How do we keep them straight?
Absolutely. Nerve sheath tumors are common, and schwannomas lead the pack. Conventional schwannoma is usually well circumscribed, encapsulated, made of plump spindle cells with elongated, tapering nuclei. Displays those characteristic alternating hypercellular Antoni A areas, that's where you see nuclear palisading and Verroque bodies, and hypocellular Antoni B areas. Plus, thick-walled hyalinized vessels are typical.
Antoni A, Antoni B, Verroque bodies. Classic schwannoma, IHC.
Almost universally positive for S100 protein and SOX10. Excellent diagnostic markers.
Okay. What about the tricky variants?
Right. Ancient schwannomas show extensive degenerative changes. You can see nuclear atypia, pleomorphism, hyperchromasia. Looks scary, but it's still benign.
Ancient change is benign. Got it.
Cellular schwannomas are highly cellular, often lacking Antoni B areas entirely. They can sometimes be infiltrative and grow large, which frequently raises suspicion for malignancy. But again, they are still S100 SOX10 positive and benign.
Cellular doesn't mean malignant here.
Correct. Plexiform schwannomas are multinodular, but importantly, they are not associated with NF1. That's different from plexiform neurofibromas.
Good distinction.
Melanotic schwannomas are rare pigmented variants, often associated with Carney complex, specifically the Samotis type, and characterized by PRKR1A mutations. And microcystic reticular schwannomas, often found in visceral locations, can mimic adenocarcinoma because they look myxoid and microcystic. But crucially, they lack significant nuclear atypia and are negative for keratin.
Wow, quite a range.
It is. Knowing these variants is key to avoiding overdiagnosis of malignancy, the core nugget. Schwannomas are S100 and SOX10 positive. Even atypical features like pleomorphism in ancient variants or high cellularity in cellular variants are usually benign.
Okay, very helpful. Now, neurofibroma, where the NF1 connection is paramount.
Yes, neurofibroma, common benign peripheral nerve sheath tumors. They have a mixed population of cells: Schwann cells, fibroblasts, Perineural-like cells with intermingled axons running through them, often sporadic, but they are the hallmark lesion of neurofibromatosis type 1, NF1.
NF1 defining lesion. Histology.
Histologically, they look kind of haphazardly arranged. Spindle cells with characteristic wavy or buckled nuclei. Abundant mast cells are typical. Variable myxoid or collagenous stroma, sometimes described as having a shredded carrot's appearance because of the collagen.
Shredded carrots, wavy nuclei, mast cells. What about atypia?
You can see focal nuclear atypia and degenerative hyperchromasia. Sometimes this is called atypical neurofibroma, but this finding on its own has no clinical significance. It doesn't mean it's becoming malignant.
Okay, atypia alone is okay. When is it bad?
The presence of mitotic activity combined with atypia and increased cellularity is highly suspicious for malignant transformation into MPNST. That combination is the red flag. This is a crucial point, especially when evaluating lesions in NF1 patients.
Mitosis plus atypia plus cellularity, danger zone.
Exactly. IHC shows S100 positivity in the Schwann cells and CD34 positivity in the fibroblasts within the lesion.
And plexiform neurofibroma.
Plexiform neurofibroma is essentially diagnostic of NF1. It's characterized by multiple tortuous nerve fascicles expanded and replaced by neurofibromatous tissue. Malignant transformation of neurofibromas, particularly these plexiform ones or deep intraneural lesions in NF1 patients, is a critical concern. It's associated with underlying RAS-MAP pathway activation and often CDKN2AP16 inactivation.
So the key nugget. For neurofibromas, the presence of mitotic activity and atypia and increased cellularity is your red flag for malignant transformation, especially in an NF1 patient.
That's the critical takeaway.
That's a very clear line in the sand for malignant transformation in neurofibromas. Let's move on to paraneurioma, which is another nerve sheath tumor, but with a different immunoprofile. What sets it apart?
Right, paraneurioma, the EMA-positive nerve sheath tumor. These are benign peripheral nerve sheath tumors composed exclusively of paraneurial cells, much less common than schwannomas and neurofibroma.
Okay, what's the typical pattern?
Soft tissue paraneurioma typically shows a whorled, storiform, or lamellar growth pattern. The cells are slender spindle cells with wavy nuclei and delicate, thin, bipolar cytoplasmic processes.
Slender cells, wavy nuclei, thin processes, IHC.
They are almost invariably positive for EMA, epithelial membrane antigen, at least focally. That's the key marker. They're often positive for CD34 too, but typically negative for S100, which helps distinguish them from schwannomas.
EMA positive, S100 negative. Got it. Other types.
There's intraneural paraneurioma, which causes symmetric nerve expansion with onion bulb-like structures around axons, and sclerosing paraneurioma, an uncommon, very collagenous nodule usually found in the hands and fingers.
What about atypia or mitosis here?
Importantly, mitotic activity or atypical features in paraneuriomas generally have no clinical significance. This is a key differentiating point from sarcomas, where those features would be alarming.
So mitoses are okay in paraneurioma.
Generally, yes, they don't indicate malignancy here. These tumors often have simple karyotypes, sometimes with dilutions on chromosome 22q.
Okay, the key takeaway for paraneurioma: EMA positivity in a spindle cell lesion with delicate processes. And crucially, atypical features or mitoses don't imply malignancy here.
Exactly. Don't overcall it.
Good advice. What about ganglioneuroma?
Ganglioneuroma, the mature neural tumor. These are benign tumors most often arising in the retroperitoneum or the posterior mediastinum along the sympathetic chain.
Location is key.
Yes, they are usually well circumscribed. Histologically, they consist of a proliferation of haphazardly arranged S100 positive Schwann cells, similar to neurofibroma stroma, but crucially, with scattered mature ganglion cells embedded within that stroma.
Finding the ganglion cells is diagnostic.
Finding those large, mature ganglion cells with prominent nucleoli is diagnostic. While rare, they can occasionally undergo malignant transformation to MPNST, so vigilance is needed. Distinction from neurofibroma and schwannoma is key. It hinges on finding those ganglion cells. Even in a small biopsy from these locations, if it looks like neurofibroma but you can't find ganglion cells, ganglioneuroma should still be favored.
So the core nugget. Presence of mature ganglion cells distinguishes ganglioneuroma. Consider it strongly for retroperitoneal posterior mediastinal nerve sheath lesions.
Correct.
Now, benign smooth muscle tumors, or leiomyomas, these can be particularly challenging, especially in deep soft tissue, because the criteria for benignity versus malignancy can be so different depending on the site. What's the most critical diagnostic concept here?
This is a significant potential pitfall, so pay close attention. Benign, smooth muscle tumors, leiomyomas, especially those arising in deep soft tissue, are actually rare outside the uterus and female genital tract. Their diagnostic criteria are heavily context-dependent.
Okay, what do they look like?
Histologically, they show intersecting fascicles of uniform spindle cells. The cells have eosinophilic cytoplasm, often fibrillary, and blunt-ended cigar-shaped nuclei. That's classic smooth muscle.
Intersecting fascicles, cigar-shaped nuclei. The challenge.
The critical challenge is distinguishing them from low-grade leiomyosarcomas. And here's a hard and fast rule. Necrosis in any smooth muscle tumor indicates malignancy. Full stop. Doesn't matter the site or mitotic count.
Necrosis, malignant. Got it. What about mitosis?
Now, the nuance with mitosis, it depends on the site. In deep somatic soft tissue, like in a limb, any mitotic activity is concerning. Generally, less than 1 mitosis per 50 high-power fields is considered benign, but 1 to 5 mitosis per 50 HPF suggests uncertain malignant potential. Anything higher is usually sarcoma.
Very low threshold in somatic tissue. What about other sites?
For retroperitoneal, pelvic, or intra-abdominal leiomyomas in women, the threshold is higher. Less than 5 mitosis per 50 HPF can still be considered benign, as long as there's no necrosis or significant atypia. This difference is critical for your interpretation depending on where the tumor came from.
Okay, site matters hugely for mitotic counts. IHC.
They are diffusely positive for smooth muscle actin, SMA, muscle-specific actin, MSA, desmin, and H. caudesmin. H. caudesmin positivity helps distinguish them from myofibroblastic lesions.
And genetics.
While uterine leiomyomas commonly have ME12 mutations, the genetics of soft tissue leiomyomas are less clear and not as routinely tested.
What about angioleiomyoma?
Angioleiomyoma is a specific, usually painful subcutaneous variant. It has abundant vascular channels mixed with the smooth muscle. Recognizing the vascular component is crucial because mitotic activity in a conventional deep smooth muscle tumor usually suggests leiomyosarcoma, but might be acceptable in some angioleiomyomas depending on other features.
So the key nugget. For deep smooth muscle tumors, any necrosis means malignancy. Mitotic counts are site-dependent with a very low threshold for malignancy in somatic soft tissue compared to retroperitoneal pelvic sites in women.
Exactly. Know your site context.
Okay. What about lymphangiomyoma or LAM?
Lymphangiomyoma, which is often part of lymphangiomyomatosis or LAM, this is almost exclusively seen in reproductive age women. Frequently affects the lungs, causing cystic changes, but can also occur as localized masses, often retroperitoneal.
Reproductive age women, lungs, retroperitoneum. Histology.
It involves spindle cells arranged around dilated lymphatic channels. The spindle cells resemble smooth muscle cells, but are often clumper. And here's the twist. They express both myeloid markers, like actin, desmin, and melanocytic markers, like HMB45.
Myeloid and melanocytic markers. That's unusual.
Very unusual and characteristic. They harbor TSC2 mutations, linking LAM to the tuberous sclerosis complex pathway. This makes mTOR inhibitors a relevant targeted therapy, which is a great example of pathology informing direct patient management.
So the core nugget. LAM is in reproductive age women, often lungs, retroperitoneum, with spindle cells around dilated lymphatics expressing both myeloid and melanocytic markers driven by TSC2 mutations and potentially responsive to mTOR inhibitors.
Perfect.
Finally, for our benign intermediate section, angiomatoid fibrous histiocytoma, AFH, known for its inflammatory pseudocapsule. What's the story here?
Right. Angiomatoid fibrous histiocytoma, AFH. This typically presents in children and young adults, usually on the extremities. It's often a multinodular tumor. Characteristically, it has blood-filled cystic spaces, often simulating a hematoma, clinically or on imaging, which can be a diagnostic pitfall.
That's like a blood clot, but it's a tumor.
Exactly. A thick fibrous pseudocapsule and a prominent peripheral chronic inflammatory infiltrate, often including lymphoid follicles with germinal centers, are key microscopic features. Really look for that lymphoid cuff.
Lymphoid cuff with germinal centers, the tumor cells.
The tumor cells themselves are relatively bland, often spindled to ovoid or epithelioid. They often express desmin and EMA, maybe CD68.
Molecular.
Molecularly, AFH is defined by specific gene fusions involving the EWSR1 gene, usually UWSR1 CREP1 or UWSR1 and TF1. These are the same fusions seen in clear cell sarcoma, interestingly, but the morphology and clinical context are totally different.
Same fusion, different tumor behavior.
While it usually has an indolent course, recurrences can happen, and late metastases, though rare, maybe 5%, are possible. So it's considered a tumor of intermediate malignant potential, necessitating long-term follow-up. Don't completely discount its potential just because it looks bland initially.
Okay, the key takeaway for AFH. Children, young adults, extremities, blood-filled cystic spaces, prominent lymphoid cuff with germinal centers, EWSR1 fusions, and remember, it has low metastatic potential requiring follow-up.
You've got it.
We've covered a lot of ground with the benign lesions and the mimics. Now let's transition to the high-stakes diagnosis.
Yeah.
The truly malignant mesenchymal spindle cell tumors, these are the ones that really keep us up at night, I think. Where do we begin?
Indeed, the stakes are significantly higher here. Let's start with atypical spindle cell lipomatous tumor.
Okay, sounds like a mouthful. What is it?
It is. Think of it as a distinctive low-grade liposarcoma. It usually affects middle-aged adults, often in the subcutaneous tissue of the extremities or trunk.
Subcutaneous low-grade appearance.
It's often poorly marginated. Shows spindle cells mixed in a fibrous or sometimes myxoid stroma. There are scattered mature adipocytes of varying sizes. That size variation is important. And crucially, there are atypical hyperchromatic stromal cells scattered about, often with occasional lipoblasts, so sometimes they are hard to find.
Atypia is key. How does it differ from regular well-diff liposarcoma?
Great question. Unlike conventional well-differentiated liposarcoma, which is defined by MDM2 and CDK4 amplification, this atypical spindle cell variant is typically MDM2 and CDK4 negative by IHC and lacks those 12q13, 15 genomic amplifications.
MDM2 negative, that's a huge difference.
Huge difference. It can be confused with spindle cell lipoma, especially the variants with less fat. But the presence of nuclear atypia, that variation in adipocyte size, and the lack of those classic ropey collagen bundles helps differentiate it.
Behavior.
It has a potential for local recurrence, if not fully excised, but generally no metastatic potential. Dedifferentiation into high-grade sarcoma is exceedingly rare, unlike conventional well-diff liposarcoma.
So the core nugget, a low-grade liposarcoma, often subcutaneous, that's MDM2-CDK4 negative. Look for spindle cells, variable fat, atypia, and distinguish it from spindle cell lipoma by the atypia and lack of ropey collagen.
Exactly. A subtle but important diagnosis.
Okay. Now, when it comes to high-grade sarcoma, synovial sarcoma is one we absolutely can't miss. It's often deeply seated and aggressive. What are its defining features, especially the monophasic spindle cell type, and why is that specific translocation so critical for diagnosis?
Synovial sarcoma is definitely a major player. It's an aggressive mesenchymal neoplasm. And importantly, despite its name, it's not related to synovial cells. That's a historical misnomer from when it was thought to arise from synovium. Don't let the name fool you.
Not from synovium. Got it. Who gets it? Where?
It accounts for maybe 10% to 15% of adult soft tissue sarcomas. Common in young adults, teenagers too. Often arises deeply in the proximal extremities, frequently near joints or tendon sheaths. Imaging might show calcifications in about 15 to 20% of cases, which can be a useful radiographic clue.
Deep, near joints, young adults, maybe calcifications. Histology, especially monophasic.
Right. The monophasic spindle cell type is the most common. Histologically, it's characterized by highly cellular fascicles of remarkably uniform, small spindle cells. They have overlapping nuclei and scant, indistinct cytoplasm. This gives it a characteristic purple or blue appearance at low magnification because the nuclei are so packed together.
Uniform small purple-blue cells. Other features.
You often see wiry stromal collagen between the fascicles. HPC-like vessels are common, and prominent mast cells are often scattered throughout.
Okay. What about the synovial part? Any epithelial features?
Epithelial differentiation, even if subtle, is key, especially for the biphasic variant, but can be focal and monophasic too. It can be shown by patchy EMA and scattered keratin expression by IHC. The most reliable immunohistochemical marker, though, for both types of synovial sarcoma is strong and diffuse nuclear staining for TLE1.
TLE1 is the best IHC marker, but the gold standard.
The definitive diagnostic hallmark, the gold standard, is the balanced translocation TX18. This creates the SS18 SSX fusion oncogene, which is detectable by FSH or RT-PCR.
The TXS18 fusion, diagnostic.
It is diagnostic, finding that fusion confirms synovial sarcoma. Its variants, like SS18, SSX1 versus SSX2, may correlate with prognosis, but histological grade and disease stage remain the most important prognostic factors overall.
And behavior.
It's an aggressive tumor, high local recurrence rates and high metastatic rates, up to 40%, usually to the lungs and bone. It requires wide surgical excision and often adjuvant radiotherapy or chemotherapy. Close long-term follow-up is critical for these patients.
So the most important nugget for synovial sarcoma, Uniform small spindle cells, purple-blue look,
Okay.
KLE1 positivity, and the definitive SS18 SSX fusion via TX18, aggressive tumor needing aggressive treatment and follow-up.
Absolutely. A diagnosis with major implications.
That's a clear-cut case where molecular confirms the morphology. What about the elusive malignant peripheral nerve sheath tumor, MPNST? This one seems to be a common diagnostic challenge, especially given its variable presentation and often tricky IHC. What are the key features and perhaps the biggest diagnostic pitfalls?
You're right, MPNSTs are notoriously difficult and highly variable, a real challenge. They are malignant soft tissue tumors showing neuroectodermal, or Schwann cell, differentiation. They often arise deeply, commonly in the proximal lower extremity, like the sciatic nerve or in the paraspinal region.
Who gets MPNST?
About half are sporadic. The other half occur in patients with neurofibromatosis type 1, NF1. In an NF1 patient, any rapid growth or new pain in a known neurofibroma should trigger immediate biopsy because the risk of malignant transformation is significant.
NF1 is a major risk factor. Histology.
Histologically, MPNSTs are highly variable. That's part of the problem. They often show alternating hypocellular and hypercellular areas. Focally myxoid stroma is common. And a characteristic feature is perivascular accentuation of cellularity. The tumor cells tend to cluster around blood vessels.
Alternating cellularity, perivascular cuffing. The cells.
The spindle cells typically have wavy or serpentine hyperchromatic nuclei and indistinct cytoplasm. Heterologous differentiation, meaning elements that look like muscle, rhabdomyosarcoma, cartilage, or bone, occurs in maybe 10% to 15% of cases. Finding that can actually help confirm the diagnosis sometimes.
Okay. Now, the tricky IHC.
Yes, immunochemically, MPNST is notoriously difficult to confirm. Only about 40% to 50% express S100 protein, and when they do, it's often patchy or weak. Not the diffuse strong staining you see in schwannomas. GFA or SOX10 are also only variably positive.
So S100 isn't reliable.
Not nearly as reliable as in benign nerve sheath tumors. This is a major pitfall. However, there's a newer marker that's proving very helpful. Loss of H3K27E3 staining by IHC.
Loss of H3K27 trimethylation.
Exactly. This loss is observed in approximately 50% of all MPNSTs and up to 90% of high-grade cases. It reflects underlying loss of function of the polycomb repressive complex 2, or PRC2, often due to SUZ12 or EDD mutations. This H3K27Me3 loss is becoming a diagnostically useful and increasingly relied upon marker, especially when S100 is weak or negative.
Okay, H3K27Me3 loss is a big clue now. How to distinguish from synovial sarcoma.
Differentiating MPNST from monophasic synovial sarcoma is a common challenge due to similar histology. Synovial sarcoma tends to be more uniform. The cells often look slightly plumper. You see that wiry collagen, and it has a specific translocation and strong TLE1. MPNST is often more variable, shows that perivascular accentuation, and may show H3K27Me3 loss.
And prognosis.
Prognosis is generally poor, especially for NF1-related cases or large high-grade tumors, high recurrence rates, and high metastatic rates.
The key nugget. MPNST is a highly variable sarcoma, often NF1 associated. S100 is unreliable, but loss of H3K27E3 is a critical and increasingly utilized diagnostic marker. Prognosis is often poor.
Precisely. A tough diagnosis, often requiring integration of all features.
That H3K27E3 loss marker sounds like a real game changer for MPNSTs. Let's talk about biphenotypic sinonasal sarcoma. This one is unique not just in its location, but its dual differentiation. What's the scoop?
This is a fascinating, relatively recently recognized entity. It's a locally aggressive sarcoma unique to the sinonasal region nasal cavity, paranasal sinuses. It has a striking female predominance and typically occurs in middle-aged adults, peak incidence around the 5th decade.
Sinonasal, female predominance. Histology.
Histologically, it shows infiltrative margins composed of long fascicles of uniform spindle cells. The nuclei are bland, cytoplasm is scant, often entraps native submucosal glands as it infiltrates.
Okay, what about the biphenotypic part?
It features a characteristic dual neural and myogenic phenotype. By IHC, it expresses both S100 protein, neural marker, and smooth muscle actin, myogenic marker, sometimes Desmond too.
S100 and SMA positive, that's unusual. Molecular.
Yes, and it has consistent PAX3 gene rearrangements, commonly PAX3-MAML3 fusions. This fusion is characteristic.
KX3 fusion. Differential.
It can mimic monophasic synovial sarcoma and MPNST because it can share S100 positivity and sometimes TLE1 expression. But the specific immunoprofile being positive for both S100 and SMA-Dsmin, but negative for keratin-SEMA along with that PX3 fusion, distinguishes it.
And behavior.
Yeah.
You said locally aggressive.
Yes, locally aggressive with a high recurrence rate, if not completely excised. But interestingly, despite the sarcomatous appearance, distant metastasis has not yet been convincingly reported. So it seems to be locally aggressive but non-metastasizing, which is quite unique for a sarcoma.
So the key nugget, sinonasal location, female predominance, dual S100 and SMA positivity, PX3 fusion are diagnostic. Locally aggressive, but currently thought to be non-metastasizing.
You got it, a very specific clinicopathologic entity.
So the term fibrosarcoma used to be a common default for spindle cell tumors, kind of a wastebasket diagnosis when you didn't know what else to call it. But that's changed drastically, right? What's the current understanding of sarcomas with fibroblastic differentiation?
Precisely. The term adult-type fibrosarcoma is now exceptionally rare. It should really only be considered a diagnosis of exclusion. It's for malignant spindle cell tumors, showing no other specific line of differentiation after a thorough workup.
So most things called fibrosarcoma in the past weren't.
Correct. Most tumors traditionally classified as fibrosarcomas are now reclassified as something else. Monophasic synovial sarcoma, SFT, MPNST, myxofibrosarcoma based on morphology, IHC, and molecular.
Okay. What does true adult-type fibrosarcoma look like if you ever see it?
Histologically, true adult-type fibrosarcoma presents as uniform, dense fascicles of hyperchromatic spindle cells, often arranged in a herringbone pattern. But critically, it typically lacks significant pleomorphism. Immunostains, by definition, don't reveal a specific line of differentiation, negative for keratins, S100, SMA, Desmond, etc. This tumor frequently recurs and metastasizes.
So the key nugget. Adult-type fibrosarcoma is now a true diagnosis of exclusion. Look for that herringbone pattern only after excluding everything else. It's rare.
Very rare nowadays. A much more commonly encountered fibroblastic sarcoma, and one you absolutely need to know, is low-grade fibromyxoid sarcoma, LGFMS.
LGFMS. Why is this one so important?
Because of its deceptively bland appearance, it's a true wolf in sheep's clothing. It can look very innocent microscopically, but behave aggressively over time.
Okay, bland but bad. What's the histology?
It's characterized by alternating, sharply demarcated fibrous areas, often with a whorled architecture, and myxoid areas. The myxoid areas typically have arcades of small blood vessels. The tumor cells themselves are bland spindle cells, very little atypia, low mitotic rate.
Alternating fibrous and myxoid zones, bland cells. How do you confirm it?
The key immunohistochemical marker is diffuse and strong MUC4 expression. That's a very reliable marker for LGFMS. And it's defined genetically by recurrent gene fusions involving the FUS gene, usually FUS CREP3L2 or FUS CREP3L1.
MUC4 positive FUS fusion. Behavior.
Despite its bland appearance, LGFMS has a significant tendency for late recurrences and, importantly, late metastases, sometimes decades after the initial diagnosis. Lungs are a common site. This makes long-term follow-up absolutely essential. You cannot be fooled by its innocent look under the microscope.
So the key nugget. LGFMS is deceptively bland with alternating fibrous myxoid areas. Look for MUC4 positivity and FUS fusions. Critical.
Yep.
Long-term follow-up is essential due to potential for very late metastases.
Absolutely critical message for LGFMS.
Okay, what about low-grade myofibroblastic sarcoma?
Low-grade myofibroblastic sarcoma. This tumor has a predilection for the head and neck region, particularly places like the tongue, face, and neck, but can occur elsewhere.
A head and neck preference. Histology.
It's composed of long fascicles of relatively uniform spindle cells. There's usually mild to moderate nuclear atypia, more than you'd see in fibromatosis. Prominent stromal collagen is common, and it often has infiltrative margins.
Looks myofibroblastic, IH.
It expresses SMA, and often Desmond, consistent with myofibroblastic differentiation. But importantly, it's typically negative for H. Kalsman, which helps differentiate it from leiomyosarcoma. Distinguishing it from desmoid fibromatosis relies on recognizing the nuclear atypia and maybe more infiltrative growth pattern in low-grade myofibroblastic sarcoma. Beta-catenin would be negative here, unlike desmoid.
So the nugget. Head and neck predilection, SMA positive, H. Kalsman negative, has nuclear atypia that sets it apart from fibromatosis.
Correct.
Then there's spindle cell rhabdomyosarcoma, a rare adult variant.
Yes, spindle cell rhabdomyosarcoma. While rhabdomyosarcoma is more common in children, this specific variant does occur in adults, predominantly in the head and neck region.
Adult head and neck. Appearance.
It shows long intercepting fascicles of relatively uniform spindle cells. The key is finding scattered rhabdomyoblasts, those cells with hyperchromatic, often eccentric nuclei, and bright eosinophilic cytoplasm. Sometimes they're strap-shaped. They can be subtle and easily missed.
Gotta hunt for the rhabdomyoblasts, IHC.
It expresses muscle markers like actin and desmin, but crucially, you need to demonstrate positivity for the skeletal muscle transcription factors, myogenin, MYO4, or MYOD1, that confirms skeletal muscle differentiation.
Myogenin or MYOD1 are essential. Prognosis in adults.
Adult cases generally carry a poorer prognosis than pediatric cases of spindle cell rhabdo, often due to challenges with achieving complete surgical excision in critical head and neck locations, and maybe less tolerance for chemotherapy.
So the key nugget. For spindle cell rhabdomyosarcoma in adults, look for those subtle rhabdomyoblasts and confirm with myogenin MYOD1 positivity in a spindle cell lesion, especially in the head and neck.
Exactly. Need those muscle-specific transcription factors.
Okay. What about clear cell sarcoma, CCS? Sounds distinct.
Clear cell sarcoma CCS is very distinct. It used to be known as malignant melanoma of soft parts, which tells you something about its differentiation.
Melanocytic differentiation.
Yes, it's a malignant soft tissue tumor with melanocytic differentiation. Primarily affects young adults, often in the distal extremities like the foot or ankle, and is frequently associated with tendons or aponeuroses.
Distal extremities, young adults, near tendons. Histology.
Histologically, it forms nests and fascicles of uniform spindle to epithelioid cells. There are prominent, dense fibrous septa separating the nests. The cytoplasm is often clear, hence the name, but more commonly it's pale eosinophilic. The nuclei are vesicular with large central nucleoli. Multinucleated giant cells, often with a wreath-like pattern of nuclei, are common. Melanin pigment can sometimes be identified, but not always.
Nests, fibrosepta, prominent nucleoli, maybe clear cells, IHC.
IHC shows positivity for a full panel of melanocytic markers: S100, SOX10, HMB45, and melan-A. Interestingly, HMB45 is often stronger and more diffuse than S100 in CCS, which is somewhat opposite to typical cutaneous melanoma.
Okay, full melanocytic panel positive.
Yeah.
Molecular.
The defining molecular feature is a recurrent translocation, T12, 22, Q13, Q12. This results in the EWSR1 ATF1 fusion oncogene. Finding this fusion is essentially diagnostic.
EWSR1 ATF1 fusion. Prognosis.
Despite its distinct clinico-pathologic profile from cutaneous melanoma, its prognosis is generally poor. Frequent local recurrences and late metastases are common, often to regional lymph nodes first, unlike most sarcomas, then lungs and bone. Mandatory long-term follow-up is needed.
So the key nugget for CCS. Deep soft tissue lesion, young adult distal extremity, nests fascicles with fibrous septa, full melanocytic marker positivity, especially HMB45, and the EWSR1 ATF1 fusion. Poor prognosis, metastasizes to nodes, needs long-term follow-up.
You nailed it. A very specific entity to recognize.
All right, almost there. What is pseudomyogenic hemangioendothelioma? Sounds like a mix of things.
It does, doesn't it? Pseudomyogenic hemangioendothelioma. This is a distinctive endothelial neoplasm, considered of intermediate biologic potential, meaning rarely metastasizing. It predominantly affects young adult men, often presents as multiple discrete lesions, sometimes involving different tissue planes, skin, muscle, bone, typically within a single limb.
Young men, multiple lesions in one limb. Histology.
Histologically, it consists of loose fascicles of plump spindle cells. They have abundant eosinophilic cytoplasm that looks strikingly like rhabdomyoblasts, hence the pseudomyogenic part. There's often a prominent neutrophilic inflammatory infiltrate mixed in.
Rhabdomyoblast-like cells. Neutrophils. IHC.
The tumor cells are diffusely positive for endothelial markers like FLI1 and ERG. About 50% express CD31. But here's the kicker. They are also consistently positive for keratins, AE1, AE3, and importantly, the transcription factor FOSB.
Keratin positive. In an endothelial tumor.
Yes, that keratin positivity can be a pitfall, making you think of carcinoma. But the key is the FOSB positivity and the endothelial markers. Molecularly, the hallmark is a balanced translocation, T7, 19, Q22, Q13, creating a SERPIN1 FOSB fusion gene. That FOSB IHC positivity reflects this fusion.
SERPINO and FOSB fusion.
Yeah.
Behavior, you said intermediate.
Yes. Despite its sometimes alarming histology and multicentricity, the clinical course is usually indolent. Distant metastases are exceptional. Knowing this entity prevents overly aggressive treatment for what usually behaves like a benign process, despite sometimes looking scary.
So the key nugget. Multicentric lesions in young men, rhabdomyoblast-like cells with neutrophils, positive for keratins and SD endothelial markers, and FOSB-IHC, driven by SERPIN1 FOSB fusion, usually indolent despite appearances.
Excellent summary.
Finally, what happens when you've done all this? Looked at morphology, IHC, maybe molecular, you still can't classify it. What are unclassified spindle cell sarcomas?
Unfortunately, that does happen. About 5% to 10% of spindle cell sarcomas remain unclassifiable, even after an extensive morphologic and ancillary workup. This is really a diagnosis of exclusion.
A heterogeneous group.
Very heterogeneous. It includes both high and low-grade tumors. Many post-radiation sarcomas end up falling into this category because they're often very poorly differentiated. These often carry a worse prognosis. The term fibrosarcoma as a default diagnosis here is strongly discouraged because it implies a cohesive entity that often isn't accurate.
So don't just call it fibrosarcoma.
Please don't. These unclassified cases are often challenging. They might represent difficult to diagnose MPNSTs, dedifferentiated components of other sarcomas, or perhaps unique entities that haven't yet been fully characterized molecularly. It's important to acknowledge when a definitive diagnosis cannot be made. You should provide your most likely diagnosis, describe any aggressive features clearly, indicate the grade if possible, and make sure the clinicians understand the uncertainty.
So the key nugget. When all else fails after extensive workup, acknowledge it's an unclassified spindle cell sarcoma. Avoid the term fibrosarcoma as a default. Describe features, grade if possible, and communicate the uncertainty.
Exactly. Honesty about diagnostic limitations is also crucial. Hashtag outro.
And there you have it. Wow, that was a truly comprehensive deep dive into the complex, often challenging world of adult spindle cell tumors.
We covered a lot of ground.
We really did. From the general diagnostic principles to the incredibly specific nuances of each entity, we've covered the information that's crucial for any surgical pathologist stepping into independent practice. It's definitely a lot to absorb, but each piece of that puzzle is vital.
Absolutely. And remember, clinical pathologic integration is paramount. We kept coming back to that, didn't we?
We did.
No single feature or marker tells the whole story. You must consider the patient's age, gender, tumor location, clinical history, and then meticulously combine your morphologic observations with targeted immunohistochemistry and, increasingly, molecular genetic studies.
Putting it all together?
Exactly. Navigating those differential diagnoses, especially for the high-stakes malignant entities, is where the art and science of pathology truly converge. And always start by ruling out the non-mesenchymal mimics. Never underestimate the power of a thorough clinical history either. That initial phone call with the clinician can sometimes save you hours of work and point you in the right direction immediately.
That's great advice. And this isn't just about memorizing facts from a textbook. It's about building a robust, systematic approach. One that allows you, the listener, to confidently tackle these cases in your independent practice.
Right.
The more you immerse yourself in these details, see these cases, the sharper your diagnostic eye will become. You've got this. Every challenging case you encounter is really a learning opportunity that will strengthen your skills over time.
Absolutely. And as you continue your journey, gaining experience with each new case, remember, this field will keep evolving. The classifications change, new molecular markers emerge.
Always learn.
Always learning. So looking ahead, in this world of pathology where a single cell can tell such a profound story, it makes you wonder, how might we leverage emerging technologies beyond our current molecular tools? Things like advanced AI image analysis, for example. Could those tools unlock even deeper insights into these spindle cell mysteries, transforming our diagnostic precision for the next generation of pathologists, maybe even help us anticipate malignant transformation before it fully manifests?
A truly fascinating thought to carry forward. What will AI bring to spindle cell diagnoses? Thank you for joining us on this deep dive. Keep learning, keep questioning, and keep making those crucial diagnoses. We'll catch you on the next one.